Hi and welcome to our first integrated care coordination video podcast. My name is Laura Bradshaw and I'm the business support officer for the ICC team, and we are joined today by Rob Till, Senior Operations Manager for the West Midlands Ambulance Service, Julie Roper, Clinical Lead for Urgent Emergency Care for Shropshire Community Health Trust, and Chrissla Davis, Head of Clinical Workforce for ShropDoc. You may have heard that there have been some changes to the call before convey process. Rob, could you tell us a little more about this and what's changed?
Thanks, Laura. Well, the biggest changes from our point of view are a central number to ring at 24 hours a day, rather than just the normal operating hours of the CCC in Shropshire that's been traditionally there. So listen to staff, really. Staff describe their phones becoming yellow pages with numbers for all different kind of organisations. And because we're a regional service, that was mirrored across each kind of different ICB area. So now crews can ring one number, select the appropriate area that they're working in at that time, and be put through to the right person. So just one number to remember. And then the other main difference will be that it's now any adults. So ring before you convey for any 18-year-old, anybody that's over 18, accepting that there is an exclusion criteria, but changing from 65 to 18.
Okay, that's great. So Julie, how does that work with the community teams then? How does it work? How does it work in hours?
Yeah, thanks, Laura. So the community teams are based in the Care Coordination Centre. So all referrals that come through the Integrated Care Coordination Centre, the teams are there together. So we're able to signpost patients to the right place. So even if the crews aren't sure about the right pathway, alternative pathway for the patient, they really don't need to be. They are signposted to the CCC team and they will direct that patient to the most appropriate route.
That's great. So Julie, the community teams, what hours are they, what is in hours? What hours are they running?
So the community teams currently work between 8 and 8 at night, so 8 a.m, 8 p.m. They're on duty throughout those hours. Patients who are referred during the external hours to the service, they can be referred through the ShropDoc route, so the call before you convey line, which Rob alluded to before.
That's great. So you touched there on out of hours. Chrissla, can you tell us a bit about what happens out of the normal 8 to 8 that the community services are available, please?
Absolutely, Laura. So the out of hours service is run by, well, it's GP led. So there's always going to be a GP or a clinician at the end of the phone. So those services run each evening from 6 o'clock until 8 o'clock the next morning when CCC Spa opens again. It also runs from a Friday evening from 6 o'clock until the Monday morning at 8 o'clock again. So if any of the crews are out there and you want a little bit of advice, or you just want to run something by one of our clinicians or one of the GPs, obviously just give us a call. We can coordinate the care together. We can pick up the patient's care. We can arrange for them to have a base appointment at our numerous locations, including Royal Shrewsbury Hospital and PRH Hospital. We also have home visits, so we have clinicians in the cars that can go out. We cover quite a rural area, so we can go out and assess those patients and treat them in their own home.
That's great. So when it comes to clinical responsibility, Chrissla, so if a crew was with a patient and they were ringing the HCP line and they were going to pass this patient over to you to hold perhaps until the community services opened in the morning, who is responsible for that patient once they leave?
So ultimately, that's a really great question, Laura. Ultimately, it's like handing a baton over. So it's like handing over when you go to an emergency department and hand over those patients. So the care for that patient ultimately it lies with ShropDoc. We will hold on to that patient. We will continue to make contact with that patient, whether that's something that we need to sort out, whether it's some transport for them to go to one of the base appointments or whatever they need to do, we will arrange that for them. So don't feel as though you're handing that over to somebody and they're sitting on a computer system. They'll be handed over to our clinicians, and our clinicians will hand that over to the CCC SPA staff and our ShropCom colleagues in the morning, so we can pick them up and get them to the right place.
That's great, brilliant. I wondered if I could ask each of you before we end today, if you could share with us a patient story that has kind of stuck out for you. Rob, would you like to go first?
Yes, certainly. So I mean, there are lots of examples that I could use, but I think I want to use an example which is a bit more unusual. So a crew had to transport a patient to the ED, and they were being held outside for a number of hours. And the community team happened to be at the hospital in the capacity of the virtual ward, and they helpfully went round some of the ambulances outside and identified that they could actually support this patient, and were able to refer that patient directly to a speciality within the hospital, so that then there was an immediate handover to the speciality. So that just really proved the point that they can open doors that we don't have access to.
Yeah, that's great. Julie, what about for you on behalf of the community services?
Yeah, I think the one that sticks out for me, Laura, is a patient that was referred into our integrated care coordination centre, a patient that had an exacerbation of COPD. The crew made that call before you convey call, and we were able to infiltrate, because the feeling was at the time that this patient should be sent to ED for an X-ray. However, they'd only been optimised on treatment for 2 days, a really short period of time on antibiotics, and not started on any steroids. So we were able to onboard that patient to our virtual ward. They were kept on for a period of 2 weeks. Their treatment was optimised on all antibiotics, which they didn't respond to, but they're able to step up to IV antibiotics and optimise their treatment. And we can refer into STEC, so we were able to refer into STEC for a chest X-ray if we needed it. On this occasion, we didn't, but obviously we can do if we should need to. So that patient was kept at home for that 14-day period, rather than being conveyed to ED and then a deeper bed base in the hospital.
That's great, and it's so much better for the patients as well, isn't it, if they can stay at home. Chrissla, I'm sure you have got so many examples of calls coming through to your line where you've managed to save patients from going into hospital. Could you share one of your stories with us, please?
Absolutely, Laura. There are lots and lots, but the one that probably sticks with me the most was actually an end-of-life patient that they didn't realise was end-of-life. So a paramedic crew had gone out to this patient because they were quite poorly and they were using very high. They called through to our call centre, spoke to one of the GPs, and lo and behold, we had one of the clinicians out not far from there. The clinician attended and allowed the crew to actually get off and arranged all of the end-of-life drugs for that patient and sorted out the syringe driver. The family then contacted the rest of the other family, and within a couple of hours that patient had passed away. But the patient passed away at home where they wanted to be, with their family around them, instead of in the back of an ambulance or outside ED or even in the emergency department. It was the family were very, very grateful that we were able to go there, and our clinician went back later on and explained the next processes from there. We had a really, really great response and a really good thank you from that family, because you just can't get that time back. But it just shows that although that patient appeared very, very poorly, they were end of life, and it wasn't as expected at that point in time, but the crews were able to get off and go and see other patients, and we were able to pick that patient up and allow them to die in a place where they wanted to be.
That's great, Chrissla. I mean, that sounds like it was a much better experience for not only the patient but their families as well. And nobody wants one of their loved ones to die in the back of an ambulance. Well, thank you all for coming on to our first podcast today. I think it's quite clear to see that this new call before convey going 24 hours is going to be great for the patients and hopefully great for the crews as well. And we look forward to hearing more patient stories as things continue. Well, that's it for podcast 1. I hope it's been helpful, and I hope anybody watching it has been able to take away some value information from our guests today. If you have any questions for our guests, you will find their emails at the end of this video. Thank you.